Finishing coming in. Oh, great, thanks. So I think most folks are just coming in, so maybe we'll go ahead and get started. And thanks so much for joining this session today. For anyone who hasn't been to these sessions before, who aren't familiar, my name is Laura Ferrer-Legier, and I'm the Senior Manager of Public and Community Engagement at ICS. And this is the Equity in Focus Speaker Series. It's a virtual event that we've been running by the Science Office. And our sessions are really to explore some of the responsible use of race, ethnicity, and other social data at ICS. So today we're going to focus our session on selecting a race-related data source in the context of your ICS research question and modeling racial health inequities. Importantly, recognizing race as a social construct is a prerequisite to today's talk and has been kind of explored in some of our previous sessions. So today's session will briefly describe how race is associated with health inequities, provide prompts for thinking critically about appropriate proxy variables in the context of your specific research question, and explore race and other social determinants of health. Before I introduce our speaker today, I do want to open with a note on Indigenous data and a land acknowledgement. So the race and related data we are referring to in today's session will not dive deeper into key considerations for using Indigenous data or identifiers. Today, we're primarily speaking to the data we have in holdings like IRCC CIC, CCHS, the Ontario Marginalization Index as well. And although these still may include data for Indigenous communities, especially when targeting specific geographic areas across Ontario, we do want to talk about the distinction as well. So for First Nations communities, the First Nations principles of OCAP, ownership, control, access, and possession, assert that First Nations own their information and are stewards of their own data. The First Nations principles of OCAP are followed in the use of different types of data that identify First Nations people and communities at ICS. And if you're interested in using data that specifically identifies First Nations or other Indigenous communities, we encourage you to connect with the Indigenous Partnerships Data and Analytics Department directly. In terms of the land we are presenting on today, Toronto is covered under Treaty Number 13 and the Williams Treaties and is the traditional territory of many First People, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. This territory is part of the Dish with One Spoon Wampum, a treaty made between the Anishinaabe, the Mississauga, the Haudenosaunee, where nations entered into an agreement to protect the land and responsibly care for its resources in harmony together. We recognize our responsibilities to engage in a meaningful, continuous process of truth and reconciliation together. I'm now pleased to introduce our speaker for today, Dr. Arjun Siddiqui. So Dr. Arjun Siddiqui is a professor and Canada Research Chair in Population Health Equity at the Dalla Lana School of Public Health at the University of Toronto and Senior Scientist at the Edwin S. H. Leong Chair of Child Policy Research at the Hospital for Sick Children. At the University of Toronto, she is also appointed in Sociology, Public Policy, and Women and Gender Studies, and is a Senior Fellow of Massey College. She holds adjunct professorships at Harvard University and the University of North Carolina, Chapel Hill. She is also a member of ICS's Scientific Advisory Committee, and her research focuses on understanding the nature and causes of health inequities, with particular emphasis on how they are influenced by social policies and societal conditions. I'm now pleased to hand it over to Arjun to lead us off this afternoon.
Thank you very much, Laura. Good to be with everyone. I am going to start the presentation. I'm sort of on the fence. I'm hoping that we can get a little engagement during the presentation, but if not, certainly afterwards will be great. So let me just go to here and we'll get started. Okay. So we're going to talk about three things today. One is just a sort of quick overview of what race is and how it's related to health. Laura mentioned that it's a social construct. We'll talk a little bit about that. The second section is to talk a little bit about what race variables or race-like variables or seemingly like variables are in the ICES environment, at least the main ones. And the third section is to talk about some other social determinants in the context of the ICES environment. So let's start with talking about what race is and how it's related to health and sort of why we know it's a social construct. I think race is often very misunderstood in public health literature. The population geneticists can't believe we're still making these mistakes, but here we are. We have a lot of both indirect and direct evidence to show that racial groups are not equivalent to population genetic groups. On the left is a graph that shows some indirect evidence, and this is data from Illinois, in which they looked at the birth weight distributions of three groups
Oh,
of moms, the kids of three groups of moms. The first group was African-born Black women, which is one of the sort of solid curves you see. The other is US born Black women, which is the dashed curve to the left of that. And the third is US born white women, which is basically superimposed upon the African born Black curve. So, in other words, the two birth weight distributions that are more similar to each other are the distribution for immigrant African women who live in Illinois and gave birth in Illinois, meaning they were born in Africa and immigrated to the US, and the curve for white women born in the US and giving birth in the US. And the curve that is distinct from those, that is sort of is slightly shifted left to a more kind of riskier distribution of birth weight, is the US born Black distribution. And you can imagine that we would consider in society for African born Black women and US born Black women both to be Black, as the graph suggests as well, and yet their birth weight distributions are not more identical to each other than the black and white one as depicted. We also have direct evidence, and a lot of this is because of the Human Genome Project and the mapping of the human genome and subsequent studies. This is a map of India, and it shows variations in genetics across India, various genetic groups in India. And again, we think of South Asian as some kind of genetic group, and it is emphatically not a genetic group. And that's not
are-
to say that there aren't population genetic groups. There are, they just don't map onto what we socially call race or even ethnicity. Um, so when we see data like this, um, this is sorry, you're seeing, I just got a
yes.
message that
I
says
was
you're
just
seeing
gonna
all the
say
slides.
if you could put to we're just seeing presenter mode. I don't know if there's a way to increase to the full screen.
How's this?
Yes, there's just one little pop-up in the middle.
Continue to share. Yeah,
Perfect. Yep,
we're
that's
good.
better.
Sorry.
Thanks.
So let me just show you the previous slide quickly. Um, so this is on the left, the US born white and African born Black women's birth weight distributions are more similar to each other than the US born Black distribution. And on the right is a variation in genetic characteristics across India. Again, the point being that Indian people are not genetically homogeneous. They aren't a population genetic group. So we often see data like this, which is differences by race and ethnicity in COVID-19 cases. And I could have shown you this basically at any point in COVID, and it would have looked similar. This is Toronto-based data, and it shows in the green bars the proportion of the Toronto population made up by each race ethnic group, and in gray bars, the proportion of each race ethnic group in terms of its share of COVID-19 cases. So you can see that particularly for Black people and for South Asian people, but basically for almost all nine non-white groups, their share of COVID-19 cases outpaced their proportion in the population. And the converse was true for whites, whom experienced about half their share of the population in terms of COVID-19 cases. And again, sort of the instinct often is to look at this data and to wonder if there's any genetic basis. And certainly we saw that in the press. Um, this was from a CBC News article where David Naylor says, I've seen this data about racial differences and wondering how much of the disease's impact on Black communities is due to socioeconomic conditions, acknowledging the social construction, and how much could be genetic. And somehow we just cannot shake the genetic argument. And this what we have learned, if nothing else, is that these groups, these race and ethnic groups, are not genetic groupings, they are social groupings. And so health differences between them have social causes, not genetic causes. It's not social and genetic, it's just social. And that's not to say genes don't matter, but they don't matter for explaining intra-ethnic and intra-racial differences. This is effectively the social explanation in a nutshell. It is that social determinants like race, ethnicity in this second from left column are what we consider fundamental causes of disease. That means that they are the root of almost every mechanism leading to almost every health outcome of which we know. That's why they're so powerful. That's why race and socioeconomics and their combination keeps showing the same pattern time after time, outcome after outcome. It's because these kinds of variables, these aspects of our social being, shape our lives every day. They shape our access to resources, they shape our experiences of everyday life, and those are sort of fundamental for whether or not we can exercise good health behaviors, whether our living conditions are stable and high quality, whether we have physiological and psychological stress, and so on and so forth. And you can start to see then that every kind of mechanism, almost every mechanism for almost every disease, whether it's depression or heart disease and so on, starts to be influenced by those variables. And the column to the far left is sort of a nod to the fact that it's not out of thin air or a necessary phenomenon that socioeconomics and race should pattern distinctions in living conditions this way. It happens because we've set up society for it to be that way, and we could undo that as well and create greater equity. So when we look at the COVID data, for example, unlike this idea that maybe it's socioeconomic and genetic, the sort of socioeconomic, the social explanation seems to be that there were higher rates of COVID amongst Black and other non-white people because of a chain of social differences in life circumstances leading into COVID. So you had differences in labor market sorting, in education opportunities. That leads to differences in job conditions and in living conditions. And those jobs and living conditions were more likely to involve COVID exposure. They were more likely to lead to people being in essential service jobs, living in dense housing, living in neighborhoods where you had a lot of people doing essential service work, and so on and so forth. It wasn't genetic, it was a social pathway that led to higher rates of COVID in Black and other non-white groups. And you can start to see that unfolding in a study like this. This is by Mishra's group, and they started to look at whether, with the ICES data, whether the proportion of essential service workers in a neighborhood was associated with the number of COVID cases, the rate of COVID cases, and the rate of COVID deaths. And indeed, it was. So if you looked at neighborhoods with higher proportions of essential service workers, those were neighborhoods that were largely Black and brown, and they were neighborhoods that had higher numbers of COVID cases. So you start to build the evidence that shows what the social pathway is. So let's talk a little bit about what it looks like to use race variables in the ICES environment. So if we establish that race is one of the key social determinants for understanding health, population health, and health inequities, the question is how much can we get at this from the ICES data? As you all know, the backbone of the ICES data is billing records from patient OHIP numbers, and this is collected by the province and includes standard sociodemographics on billing records, which is age, sex. I put sex in some quotes because there are some reasons to sort of wonder about the extent to which sex actually is sex or gender. We can talk about that as well. And postal code. And the reason that's a socio-demographic is, of course, your neighborhood shapes your living conditions, and and people tend to be in neighborhoods that look quite differently in terms of living conditions and social conditions. And you can get at that through census data linked to postal codes, which we'll go into. There is no intentional population-wide collection of race data at this time. So we don't have race data for everyone that we have in the ICES environment, for whom we do have ICES billing data. So it means that we don't have the same data that we have. We don't have the same ability to look at age the way, to look at race the way we do age or sex or postal code, which we do have for everybody. And so that's kind of a fundamental caked in feature. And so the question is there ways that we can still tap into race for some of the population within the ICES environment? And the answer is yes. And the first way is to use the Canadian Community Health Survey. The Canadian Community Health Survey is a national survey done by Statistics Canada of about 100,000 people every year. And the population of the CCHS that is from Ontario has been linked into the ICES environment, meaning they are linked into the billing records data. And the advantage of CCHS is that it actually contains many sociodemographic variables at the individual level, which is rare in the ICES environment. So we don't have a lot of sociodemographic information in the ICES environment. The CCHS is one place where we have a substantial amount. So if you are using CCHS linked data, you have access to that information. The race question in CCHS is basically the standard question that is used by Statistics Canada, which is something to the effect of people living in Canada come from many different cultural and racial backgrounds. Again, we sort of slippery with our language. Are you white, Chinese, South Asian, Black, Filipino, Latin American, Southeast Asian, Arab, West Asian, Japanese, Korean, or other? And you can see from this list, not only is it not genetic, but you can sort of see that we could have questions about these categories. For instance, Asians are quite delineated. Black people are not. They're one group, whether you're from Africa, Caribbean, etc. And there are many kind of socio-political reasons for these categories. People in the CCH dataset can also choose multiple categories and be from multiple racial groups. The big issue in the ICES environment, and frankly for the CCHS, even at the national level, is that there are not that many non-white respondents. And so you start to really come up against sample size restrictions and start to have to make some often very difficult decisions about how to collapse race ethnic categories in a coherent way. Ditto for the multiple categories people, the people who are who identify by multiple races. Often there's not enough of them to analyze as a group, and again, we can talk about this, but it's not clear that they are a coherent group anyways. We did a paper a while back, and it kind of demonstrates some of these difficult choices that often come up with the CCHS. Um, Again, you can see that the question that it originates in the CCHS, we didn't have the sample size to use all of those categories. Moreover, had some questions about whether those categories made sense at all. But the real limitation was the sample size. And you can see on the right the categories that we ended up selecting. The white, Black, Hispanic, and Asian categories were selected because they represented groups that we felt were socially recognizable. So, in other words, we looked at the possible categories, and when we thought about collapsing them, what we wanted to know is how your race affects your social experiences, your access to resources, and therefore your health. And so, if that's what we're trying to capture, we want to know what social groups are sort of used in society to categorize people on a daily basis. And so where we landed with that was white, Black, Hispanic, and Asian. We added the term Aboriginal as a category. We were working with Public Health Agency of Canada. This is 2016 data. And that was a category that is constructed with a slightly different question. I can go into that as well. But the idea was that if you look at different Asian groups, particularly, say, Chinese, Southeast Asian, it's unclear whether it makes sense to analyze those separately in the first place. But certainly, if you're faced with data limitations, it's reasonable to collapse those two groups. It's less reasonable to collapse Chinese with Black. And the idea is, how is your group socially recognized and therefore socially treated in society? What are the social groups that we are most likely to recognize and use in society? So the next data set is the Immigration, Refugee, and Citizenship Canada Administrative Data, which is the IRCC data. This is immigration data for everyone who immigrated to Ontario after 1980. It is not data for people who first land in other provinces. And so, for example, my family first landed in BC. I moved to Ontario as an adult. I am not in the IRCC database that is linked into ICES. Um, that data has quite a lot of information on if you did immigrate to Ontario, on your country of origin, your language. It has a host of variables related to your essentially your country of origin and the characteristics of that country. Um, what it doesn't have is a direct measure of your race. And so we often use your country of origin as a proxy or pseudo proxy for race, but it's actually not a great proxy for a lot of countries. So I'll give you an example. If you immigrate from China, there is a very good chance that you are racially, ethnically Chinese and therefore would be categorized as Chinese or Asian. If you immigrate from the Caribbean, from Africa, from the UK, from the US, we don't know what your racial background is. It really could be anything. And therefore, a sort of assuming race from your country of origin starts to become a very big problem. So, one major issue is that the IRCC data is not actually data on race ethnicity. It is data on your country of origin. in a few isolated country cases, I shouldn't say isolated, but in a few cases, it's a reasonable assumption that if you immigrated from a particular country, you are of a particular race ethnicity. But for a lot of countries, it is not reasonable to assume that. The other issue is that because the IRCC data only is available for people who immigrated first to Ontario, the rest of the population doesn't have any data at all and is some large generalized population. And so sometimes when you look at ICES papers, what you see is that people who are not, when you're comparing people in the IRCC database to others, you see the term non-immigrant used. The issue is that's actually not very accurate because the general population has both immigrants from other who first immigrated to other provinces, as well as presumably non-immigrants. So we're inferring, and I think incorrectly inferring, who the comparison group is. And so in one way, it's not unreasonable to say, look, we have this great IRCC data, and we're at least going to see what's happening by country or region of origin compared to the quote unquote general population. But it's very difficult to do much more than describe. It's very difficult to do anything causal with that. And it's again still pretty dicey because that comparison population is very heterogeneous. Um, if you look at papers that have come out using that immigration data from ICES, you often see something like this. This is a paper that looks at adverse outcomes amongst infants of immigrant women according to birth weight curves tailored to maternal world region of origin. And so this paper is sort of asking whether we should have different birth weight curves for people from different from different maternal world region of origin. And one question we might ask is how does this kind of terminology come about? It's not a term you see in the race ethnicity literature. It's not really a term you see much in the literature at all, but it's a function of the ICES kind of data setup. And I think the fact that this is how we're having these conversations about race ethnicity. We're kind of figuring out what do we call this and why. And the question that I would have looking at this paper is what are we trying to measure? When we say maternal world region of origin, what is it that we think differs by maternal world region of origin? And again, this is that sort of when we aren't explicit about what we're measuring, we run into some slipperiness about how to infer differences. So this is their data. You can see on the left-hand side the way they organize world regions of origin. Europe, Western nations versus Africa and the Caribbean versus North Africa and the Middle East, Latin America, Eastern Asia, and South Asia. So I leave it to you to sort of think about what the authors might have had in mind. They were not explicit about what world region of origin might be trying to convey. And so I leave it to you to sort of judge what do you think they were trying to get at with this term? What were they trying to measure as differences? The next form of race data in the ICS environment, and really the last major form. So I'm sort of going over the three major forms of data that are available that have race or race-like or race confusing variables. And so the third is Statistics Canada derived data on area level ethnic concentration or proportion racialized, et cetera. And this data comes from the Statistics Canada long form census, which is where people in Canada are asked a sort of long battery of questions about their sociodemographics, socioeconomics, etc. And after we get that information, which is collected from 20% of the Canadian population, Statistics Canada then organizes area level metrics of those sociodemographics, things like median income, employment rate, and so on. And they tell us what the proportion or median income, proportion of unemployed, median income, proportion of racialized people, et cetera, are in a certain geographic area. And those geographic areas are delineated by census level area designations like dissemination area. So in practice, the ethnic concentration or proportion racialized type variables haven't been used by themselves in the ICS environment. Instead, people often use what is part of the Ontario Marginalization Index, which is a racialized and newcomer population index. Again, in some ways, this is very handy because it's a prefab index and it can be useful for description. But part of the issue is that racialization and newcomerness often don't work in the same direction for health. We know that recently arrived immigrants are often healthier and their health declines over time, whereas non-white groups tend to be more unhealthy and their health tends to be worse than those of whites. But it's also true that not most newcomer immigrants are non-white. And so what you often see is initially non-white groups look better. And then you see their health decline over time as their immigrant advantage and the resources and resilience that led to their immigration start to wane, and discrimination in Canada starts to compromise their lives. And so, if you have racialization and newcomerness in the same index, you may run the risk that you're sort of at least getting a mixed or unclear picture of what you're measuring. Um, and again, for description, this may be somewhat adequate, but it's not sufficient for causality, where you would really want to account for race and newcomerness in quite systematic ways. Um, the other kind of issue that we run into with this Statistics Canada area level ethnic concentration, or even the racialized and newcomer population index, is that it sometimes creates some confusion with interpretation because the measure itself is an area level measure. And so the question is, what does it mean to be individually of a race versus live in an area that has a high proportion of a particular racial group? That signifier of a high proportion, let's say a high proportion of South Asian, that may mean something more than just how many South Asian people live there. And conversely, it may not apply to every individual in that neighborhood depending on their race ethnicity, which we don't know because proportion South Asian is an area level variable. So all of these are kinds of sticky issues as we kind of look to using this data. This is a paper from the ICES environment where they looked at cardiogenic shock and found that it was more prevalent in this on-marge racialized and newcomer population index. And so here you have it. You have sort of a greater frequency of patients admitted with cardiogenic shock as the proportion of racialized and newcomers in the area they live in goes up. Does that mean there are that racialization and or newcomerness is associated with cardiogenic shock at the individual level? I don't know. I don't know if this area level measure of race and immigration is is reflective of an individual level relationship, or whether race and newcomerness at the neighborhood level is its own has its own interpretation that isn't reducible to the individual level. So there are other ICES data linkages that provide some race data. Um, a lot of them are what I've called one-off or sparsely sampled. So one-off because they happened for a particular reason at a particular point in time. COVID data is a great example of that. And the other is sparsely sampled. We have community health clinic data, but if you look at that data, there's a lot of missingness. And this is sort of a maybe growing pains issue of a society not accustomed to collecting this data. But nonetheless, what ends up happening is that you have a lot of missingness and I'm sure preaching to the choir, but then obviously concerns not just for sample size, but selection bias in terms of who is responding and who isn't. So what I would say is that the number one issue is to understand what is it we are trying to understand or infer. What is our working definition of race, and what is our understanding of why we think it's associated with our health outcome? Are we trying to describe the lay of the land, or are we trying to infer causality? And of course, that happens, that's sort of on a spectrum and not a binary. Are we aiming for individual inferences or area level or ecological inferences? And who is in our reference group? So we talk often about who's in the main group that we're trying to study, but very often in the ICES environment, the trouble is in interpreting who the reference group is. And so in the CCHS, that's less of an issue because we have individual level data for everybody who is in the CCHS and linked. But for example, as I mentioned, for the IRCC data, it's unclear who composes the reference group. Because we don't have immigration data on everybody. So we don't know who is not an immigrant. We don't know who immigrated from another province, etc. And finally, the idea is that there are sort of a ways of understanding the complex causal mechanisms at play, and then those are very often contrasted with the limitations and the realities of the models that we can run. So this is just, again, the sort of main overall conceptual model we have for understanding how social determinants like race impact health. And then there are sort of very intricate ways to understand how these variables all interact and intersect with each other. This is just a hypothetical DAG, directed acyclic graph that shows how and why race ethnicity might be associated with mortality. And in this case, they were looking at whether the main hypothesis was about occupational characteristics, whether race affects occupational characteristics, which then affects death. And they put in their DAG a host of variables that are also involved in this story. And the idea is that this is great, but there's a few things. One is we often don't have a fully specified DAG or conceptual model of how complex sets of variables relate to each other, especially because they tend to play more than one role. So race and SES, for example, tend to be mediators and moderators and so on, and confounders for that matter. And then the data demands of testing a fully specified DAG are incredibly high. So very often, I would say 99% of the time or more, we are unable to fully account for the relationships we think are operating. And so, what we often resort to doing is taking care of major sources of confounding. And people who are familiar with DAG theory know that there's systematic ways to think about that. But the bottom line is we basically do our best, given that we know that there's a much more complex reality underneath. And what many epidemiologists suggest is that we should stop kind of thinking of our models as fully interpretable. So when we control for variables, when we're trying to examine race or other variables, their sort of sensibility is that we should admit that we have a good sense of the relationship and between our principal independent variable and our outcome, not a good sense of how all of the other variables relate to each other, even though they're in our model. And that we should really try to abide by two things. One is don't put mediators of your relationship in the model. So if you think a variable is on the pathway between your independent variable and your outcome, and you control for it, you are controlling part of the effect of your independent variable away. And the second, this idea of table two fallacy is to not interpret the covariate coefficients that you get. So, in other words, they're saying we know that these are variables that we should account for that surround the main relationship we're trying to investigate, but we can't possibly interpret how they're related to the outcome because we haven't modeled that appropriately. We've modeled vis-a-vis a main independent variable. So, sorry, this is a paper that I'm on actually. Just to show you, I can sort of tell you errors I've made myself. So this is a paper on inflation, the relationship between inflation hardship and experiencing distress. So inflation hardship on this left-hand side is our main independent variable. And we also looked at interactions with gender. But our controls on this right-hand side, age, race, education, household income, etc., are all involved in the relationship between inflation, hardship, and distress, but we don't exactly know how, nor have we modeled it. And so the idea is in table two fallacy, they actually recommend not putting in the coefficients for the control variables, just as a sort of visual representation to say, you can interpret this main effect, you cannot really interpret these other coefficients. Uh, so let me actually go to the last section, which is about other social determinants in the ICES environment. Um, Again, so we're dealing with an environment in which the backbone of the data is billing records. And then there are data linkages like there's race that have other variables. And essentially, it's the same data sets that contain most of the social determinants data. It's the CCHS at the individual level, it's IRCC for immigration data, and census level, area level data for other social indicators. Uh, Many of you will be familiar with the on marge, which is the principal kind of social determinant variable that you see in ICES data outside the IRCC work. And the on marge has four indices: household dwellings, material resources, racialization, and age and labor force. And each index, it's sort of dimension of on marge is a separate index and can be analyzed separately. And largely in ICES data, that's what we see. So this is a paper on the relationship between neighborhood material deprivation and severe maternal morbidity in the ICES environment. And you can see they say that they linked the discharge abstract database in ICES with OHIP claims. Then they use the mom baby file. They linked that to the IRCC data. And then they linked all of that to the census level on March. And so all of those data linkages created for them a data set with the outcome, with the main variable of interest, which was the on marge, and with covariates they wanted to include, which is primarily where the IRCC data came in. And you can see that they, in their results, they did a better job than we did in our paper because they showed only the principal finding, which is about the on marge. They did not show the coefficients for their covariates because, again, very difficult to really make much of the coefficients you find with the covariates. And again, you sort of have to wonder, what are we inferring here? Are we inferring that there's something about the neighborhood that is affecting our outcome, or is this our way of almost suggesting some socioeconomic fact about individuals? And it's very, very slippery to infer anything at the individual level from area level data. But we often see it, this paper didn't do it, but we often see it done. And I think we have to be careful. Um, this is the earlier data I showed you on essential service workers and COVID. And it's an example of other census level data that we can use through the ICES environment, but that we often don't. So we often go to on march, but in this case, essential service workers were a particularly specific pathway through which these authors felt that COVID exposure was operating. And so they looked at area level proportions of essential service workers. Same question. Um, is this a kind of way to figure out whether being an essential service worker carries risk for COVID, or is the proportion of essential service workers some kind of variable representing some other construct, maybe related, but another distinct construct from individual essential service work? Is it a distinct exposure? So I think where we kind of land, sorry, is that we have this general sense of social determinants and how they relate to health. We have a general sense of how race in particular relates to health. The main issue is that these are fundamental causes. They are the root causes of many mechanisms leading to many outcomes. The the underlying reality for any given research question that involves these social determinants is very complex, and we often don't have a full way to kind of account for all of this. There are key general principles, as I sort of tried to go over some of during this talk. Oops. But the devil is always in the details. And that's where knowing the literature, knowing your question, your data, and so on helps you make analytic decisions. And I think that's what we're trying to sort of convey, is that there will always be some thinking that is required in order to use the data best and to understand what inferences you are trying to make and which ones you can ultimately make with the data available. Leave it there.
Great, thank you so much, Arjun. I think that was a really helpful overview, and folks may recognize some of that content if you attended the workshops earlier this year as well. There's just kind of a good kind of piece there also on some of the data that we have at ICS and how it can be used. There's already questions coming in, so I'm just going to jump right into it. So the first one is, do we know why there is no intentional population-wide collection of race data? Is it logistics, privacy concerns, data validation, or something else?
I have to say, I'm not really, I have some guesses and they're somewhat educated guesses, but I am not an expert on data collection. I'm more a secondary user. I think there's a combination of things. I think probably there are some logistical concerns, but my best guess is that some of this is sociopolitical in many different directions. So one is that we are a society that has a hard time talking about race and ethnicity. We are a society that I think likes to think that this is sort of a US problem. I have a friend who lost his CRC chair because he said the words black and white, and a Canadian reviewer told him that was racist. So we have a lot of hurdles to overcome in that way. And then there's socio-political issues in terms of data ownership, what can be done with the data, whether people can be compromised in their lives, in the justice system, in the education and job markets by people using the data for nefarious purposes. And so there are also concerns about what it means to collect this data systematically. And so all of that, as I say, I'm not an expert. I couldn't possibly tell you um, uh, where we should land. I can only tell you that without the data, it is very, very difficult to know what is happening and also how changes in society are affecting different groups. So that is not to say that we should disregard very real concerns about data collection. As I say, I don't think I'm equipped to make the decision. I can only tell you that when there is data, it is very helpful for understanding not just that there's inequities, but how inequities respond to societal conditions and societal changes. Very quick example. In the US, because there's race data everywhere, they know what the racial differences are in employment status over time. And you can then say whether employment is improving or not for different groups at different times. Are the inequities rising? Are the absolute levels changing? And so people say, oh, Trump, unemployment went down under Trump for Black people, and it did. But the gap remained the same and it went down under almost everybody. Like it's just not, so you can't adjudicate that and have a reasonable discourse about it until you have the data.
That's great, thank you. So another question, is there a list of countries that IRCC's country of origin can map to a particular race?
I don't think there's a list. I think this is where you have to sort of work with people who have some expertise. So, um, a lot of people, particularly in sociology, have expertise in understanding how communities and societies understand race. And so my recommendation would be that, at least eventually there's a way to connect to those kinds of people. The reason that I can tell you about it is because I was trained in the US where we learn about this very early. And so if we're in a place where we don't do that very much. We probably need to be more deliberate about it, but it's an expertise to understand how race operates in society.
On a similar question, kind of related to the data. So the question is, when using CCHS data for race-based analyses, should we use the first reported race or the most recently reported if a respondent's race or ethnicity changes across cycles?
Again, this is such a good question. I think there's no good answer to that. There's always going to be different reasons to use initial race versus subsequent race. In fact, some of these experts on race will show you that people's racial identity can change over time, over space, in different contexts, and so on. So, what I would do is probably figure out how many of those people there are, and whether it's a real phenomenon worth capturing. If it's not worth capturing, if you're happy with it's a small portion, a proportion, and you think that it's not going to lead to much misclassification, I would pick a time point. Probably the initial one is my gut instinct because it's the start of your study. And so you have a baseline characteristic. You can also characterize those people as their own category if there's enough of them. So I don't think there's a single way to do this. The bigger issue is to ask yourself, what does it mean that people are changing their race? How many of them are doing this? Is this actually a phenomenon that I want to capture and understand? Or is it somewhat of a side issue compared to the primary hypothesis I have? And then if it's a side issue, you have to decide whether that means dropping those people. Does that lead to some bias? Do you add them to a category? Do you make a separate category of them? How do you interpret that? These are all things to think through.
Mm-hmm. I have time for a few more. So there's also a question here. What are your thoughts on treating missing race ethnicity as a separate category in order to not exclude them, assuming there is a common reason on why race/ethnicity was not collected?
So I don't know that we know there is a common reason. I would still say it's okay to include them as a missing category and to say that it is not interpretable. So I think what you do is you basically say, uh, you know, it gives you more power for maybe other analyses to keep this group in, but I don't think you can begin to interpret why that data is missing. This is also, by the way, true for people of mixed race. So we don't really know how people of mixed race are identified in society, how they identify themselves in society, the former being the bigger issue because this is about how you're treated. And so it is often very difficult to interpret um, what what to sort of impute what the lives of mixed race people might be like. There's an entirely large literature on being mixed race, both sociologically and in the health literature. But there is this problem of interpretation in all of these cases.
Just looking at the time, we have about a minute left. I just want to also pause and see if anyone on the call in real time wanted to ask any last questions before we wrap up. Great. And if we've missed any, oh, sorry, there is a question. Go ahead. Sorry.
Sorry, can I ask a quick question? You
Yes,
did
go ahead.
mention the ethnicity surname algorithm, and I'm curious what your thoughts are on whether that should be used these days ever or not.
Yeah. I'm not a fan of that source. I have a feeling ICES has sort of uh, not been using it very much lately. I'll say a couple of words about what I think are the issues. Number one, it is a data set again that makes a lot of presumptions about race ethnicity based on last name. It is only, as far as I know, for Asian last names. So I don't know who your comparison group is, even if it's accurate. And so I'm not sure what kind of analyses one could do. I guess describe Asian people or presumptively Asian people compared to everyone else. I'm not sure what that tells us because of the heterogeneity of everyone else. So maybe there's some specific way, if the algorithm is indeed reliable, that that data can be used. But by and large, to understand the relationship between race and health doesn't seem like a particularly helpful variable. And I should say the reason that you probably only have Asian names in the algorithm is that many other surnames cross racial boundaries a lot more.
Great. And I do notice we're at time, so I will leave it there. I will just say a note on the last point. We did hold a session back, I think it was almost a year ago, at least, that we also talked about this data source, so we can share that link as well. I know there's some questions we didn't get to, so we'll try to also respond to those after the fact. But just a quick thank you to Arjun. Thank you so much for this really, really helpful talk today. Thank you everyone as well for joining us. And just a quick final note that our next session will be on the Born data set, and that'll be on December 4th at noon. So thank you so much, everyone.
Thanks, everyone.